So, welcome everybody to this second Restoration and Recovery webinar. This webinar is looking in detail at planning for children and young people's mental health services. And the chair of this webinar will be Dr. Gavin Lockhart, who is consultant clinical psychologist and clinical lead for children and young people's mental health for NHS England, for South East Clinical Network, but also temporarily across the South East Mental Health Learning Disability and Autism Cell. And my name is Becky Furlong. I'm Children and Young People's Mental Health Improvement Manager, traditionally working in Hampshire and Thames Valley Clinical Network, but now working across the South East as well. So here are some housekeeping slides. So as I said a minute ago, this webinar is a live event. We are recording. Please stay on mute unless you're a designated speaker. The webinar is recorded and will be sent to participants and those who weren't able to join this event afterwards. Please do use the chat function to ask any questions, and we will have a lot of opportunity for question and answers. So do ask your questions in the chat. And if you can't access the chat box, please do email me and we can pick up your questions. If we run out of time, we can try and follow this up after the meeting. So do ask your questions and we will try and capture all of those. The purpose of this webinar is to focus on considerations in the ongoing development of restoration and recovery plans for children and young people's mental health services in response to COVID-19. And we just want to take this chance really to thank you for making the time to attend this webinar across the South East. We hope this is helpful. As we're operating across the South East at the moment, we're trying to minimise the email contacts and meetings, but just hold the most valuable meetings and really consider that to support all systems. So as I said, this webinar has been arranged to help all systems across the South East and can be used by all providers and commissioners of children's mental health services. The webinar is divided into two really, and the first aim is to focus on the evidence and data that might inform restoration and recovery planning, how this evidence is understood and interpreted, and how this might translate then into predictive modelling of changes to demand for, so any changes in your demand for children and young people's mental health services in response to COVID-19. So building on this, the second part of the webinar is really to share some best practice examples of predictive modelling and restoration and recovery plans from services. And today we're delighted to welcome the Hampshire CAMS service, and we're also delighted to hear from Oxford. So the head of CAMS, Andrea Shand, and the commissioner in Oxfordshire CCG. This is the agenda for you, which you hopefully would have all seen, and there are plenty of time for questions. So I'm just going to stop sharing temporarily. So I would like to, before we go on to the first part of the webinar, we're delighted to welcome Anne O'Healy from the National Children and Young People's Mental Health team, who's just going to give an update from the national team about restoration and recovery plans and how we start looking at aligning these to our local transformation plans. Thank you, Anne.
Good morning, everyone, and thanks Becky and Sally and all of the South East team for all your support in helping to deliver our ambitions and managing, responding to the impact of the COVID-19 response. But also thanks all to the services as well for switching so swiftly to digital, and some of the areas have provided us with really valuable case studies for us to demonstrate how things have continued and how we continue to improve and support children and young people during this difficult time. I'll just introduce myself in a little bit more detail. So my name's Anne Hurley. I'm one of the programme managers with the national team at NHS England for the CYP mental health programme. And I also support the integration between CYP mental health and with our CYP colleagues who support physical health programs. Just to give you an update, Becky asked me to give you a brief kind of verbal 10-minute update just on our current areas of focus. I think many of you are waiting for a follow-up letter to come out from Claire Murdoch, which will be coming out to the system later, just to kind of highlight work that's gone on in the past and our key ambitions and priority areas for the future. But I'll just take you through, where we are in terms of the key areas of focus at the moment and where we're working on. But I would say that we are very impressed and kind of, really heartened by how quickly most of the areas across the country have swiftly kind of moved towards kind of offering remote ways of working to continue to support their children and young people and their parents and carers within the system. Of key focus for us, and that is also included in the NHS long-term plan, is our continued need to improve our crisis response, but also our community CYP mental health services. So our continued focus to improve access and improve, support the workforce and enhance the workforce as we go forward. So while we have made progress, during our 5-year forward view for mental health kind of ambitions, we have a lot further to go, and we are continuing to kind of build on the progress that has been made to date and the progress we want to make in the future. And a key part of that is thinking about how we optimize our delivery of care and maybe thinking about how we combine, the learnings and the evaluations from remote ways of working now to combining that with face-to-face meetings appropriate to clinical need and preferences of the children, young people and the families we work with. We're also thinking about how we can improve the whole pathway across the system, including integration with our inpatient CAM services so that we help support children and young people being treated as close to home as possible. And, their admission is only part of their pathway and for the shortest possible time in an inpatient unit appropriate to clinical need. And so with that is embedded in our crisis response, and in that crisis response work, while we have quickly rolled out our ambitions for achieving 24-hour, 7-day-a-week response across the country, what we're really focusing on now is the quality of the response, the variation across the areas in terms of what's an initial response, where there's more of a outreach intensive follow-up, and where home treatment services are being developed. And also focusing on, the training needs and the skills and competencies of the staff working with children and young people, as well as adults. So different areas are working and supporting their staff in different ways, and we will be taking the learning from that as well. Digital therapies is a key area of development that again was planned for, in the future, that we've swiftly had to put in place very quickly. What I would say to everyone, if you haven't seen the webinars that are available on our NHS England platform, please do look at them, because all the evidence and the learnings that we have established so far and best practice models are described in a series of remote webinars focused on remote ways of working with our clinicians and academic leads in this area. So there is a lot of resource and information on those webinars, so please do look on our NHS England platform. The other commitments that we're focusing on is the additional investment to the youth justice services. We will continue to look at reducing waiting times and increase support for children and young people with learning disabilities and autism. And we very much are, within NHS England, working across all our programmes of work that relate to children and young people to support that integration. And then the other NHS long-term commitment about, working to ensure 6,000 highly vulnerable children and young people with complex trauma receive consultation, advice and assessment and support within the system. And our continued focus as well on improving access. So as you know, I think most of you know that the NHS long-term plan has a commitment for improving care for the 0 to 25s, and this is across both the mental health programs as well as the physical health programs. So it's supporting that integration between adult mental health and children and people's mental health. And again, that integrated way of working across the system, as well as, so there's the kind of focus around between adult services and children and people services and how well they integrate and support transition and remove the barriers to transitioning between services so that we're responding more to need, but also the integration between physical and mental health care. I think most of you know that our overall ambition is that by 2023-24, we aim to see at least an additional 345,000 children and young people aged between 0 to 25 will be able to access NHS-funded mental health service. So that's a kind of key programme that is a target shared between the adult mental health and the children and people's mental health work streams. Over the next 10 years, we are aiming for 100% of children and people to be able to access services as required and as they need. So a key part of that ambition is that we continue to ensure we support staff and their well-being, particularly during this difficult time, and constantly monitor and support staff throughout the pandemic, but also thinking about future continuing professional development using the courses available and supported through HEE's Recruit to Train programme, but also thinking about the new staff we want to bring onto the system and train in evidence-based interventions so that we increase and enhance our workforce in CYP mental health care. And in terms of, Becky, I think you also wanted me to speak briefly about the local transformation plans. Is that correct?
Yes, I think what we want to do is now start aligning what is the ambition in the NHS long-term plan and how we look at local transformation plan and then restoration and recovery and how we do that, please.
So what I've outlined just now are all the kind of key priorities within our ambitions for the NHS long-term plan, taking into account the impact of COVID-19 and our use of digital therapies and remote ways of working. We are very much encouraging the system to continue to use their children and young people's mental health local transformation plans to not only demonstrate the progress that you have made so far, detailing out how you're enhancing your services, your key areas of work, but also as a record and, account of how you are adapting your delivery to meet the needs of young people during the pandemic, and how that's and then how that impacts on your restoration and recovery plans in the future. So continuing to use the local transformation plans as your kind of resource to say to your children and young people and the wider system and families locally what the ambitions continue to be and what the plans are for the future. And there is that kind of level of transparency. But what we've also found is that, there's a lot of churn within the system, and our senior leaders and the local transformation plans provide a really helpful resource to keep track of progress because they are refreshed and revised every year. To support this, we will, through the NHS platform, hopefully kind of provide guidance and key indicators that people can kind of review their plans against and kind of just to aid the development of the plans or the revisions of the plans. And we will be working with our regions and with continue to work with Becky and Sally across the clinical networks and best practice groups across the region. So I think, Becky, that's really all we can say at the moment about the local transformation plans, but they will, but we would encourage their use. And again, it's all about the local transformation plans, and the revision or updating every year is about bringing all the system partners together, working in partnership to think about how the needs of the local population are met and building on that. But a lot of the clinical networks have also pleaded for a push towards the plans, including kind of being more data driven so that they can demonstrate progress so far through graphs and through the data that they have captured and then what they're continuing to build on. So I think I'll finish there, Becky, if there are any questions. I hope I haven't gone over my time, sorry.
No, you're fine. You're fine. Thank you, Anne. So I'm going to ask those attending if you can ask any questions. So if you can either put that in the meeting chat or raise your hand if that's okay through the toolbox. So Gavin?
Hi, Gavin. I think you're on mute.
I am on mute. I took myself off and put myself straight back on immediately. Just in terms of that figure, around 345,000 young people, is there any hint at all of whether that might be adjusted if we do see a not just a surge but a sustained increase in the prevalence rates of mental health in young people?
Certainly we're looking, and I think that my colleague Jessica Sharp and Anna are looking at how we count for the 345,000. So that is very much a piece of work that is in development at the moment. You've highlighted the reason why it's very critical that we continue to improve the flow and quality of the data to the mental health services data set, because that is the only way that we will be able to adjust and assess the surge in demand that is expected, when the schools reopen and when GPs start to refer more in September and October. In terms of prevalence, we've had a major prevalence survey done, the last year in 2018, and I'm not sure what the plans are for future prevalence studies. So I think the main source of information and data is going to be the mental health services data set. So I really would plea with everyone, if they don't have their provider system set up to work with their clinicians to ensure that it's also clinically useful for the clinicians, but we are flowing good and comprehensive data to the mental health services data set.
Thanks, Anne.
Okay. Jackie, you're on mute, I think.
I am, sorry. So there's several questions coming in now about the time frame for updating transformation plans this year.
Okay. I'll just put a holding kind of comment on that. We're not going to be hard and fast, but I think we have spoken to the regions about what their preference would be, and it certainly indicates that I think managed on a regional level with a deadline for it to be refreshed and published and available to the local population by a certain time point, but there is no definitive deadline at the moment. But ideally what we want to do is encourage the system to use them and continue to use them for your own purpose and to support your business plans and your planning going forward, and make them available publicly as soon as the regions feel that they are sufficient quality. But this year I think we won't want to put too much pressure on the system, so whatever assurance processes are put in place, they'll be light touch, and we'll really be thinking about working to support the regions in supporting delivery. But we do appreciate all the work that you have done, and the value of the clinical networks and the regional support has been essential to meet our 5-year forward view for mental health ambitions, as well as our long-term plan ambitions.
Okay, thank you. Does anyone else have any questions? Or comments?
Does Gavin still have his hand up from before?
Yeah, I think so.
Is there a new question?
So,
sorry, left it on now.
So what?
That's okay.
So just to pull out, because obviously we're working across the Southeast, and Kerry's put in the chat that, so for our systems across the Southeast, we're waiting for the Claire Murdoch letter, and then we're starting to think now as a team about how we can reflect what the national team and what Anne has just said. So yes, that information will come out, but that will be in dialogue with each of the systems across the Southeast. But I think we are waiting for Claire Murdoch's letter and then take.
We are.
So that's why it's a bit difficult, but we just need to wait and see what that says. Thank you.
That's right. I think the letter is imminent, but we have been, there are reasons for today, but it will be out soon.
Okay. Well, thank you very much, Anne, for your time, and we will now move on, but thank you for joining us today.
Okay, I'm going to stay on till past and I'll leave for an hour and then I'll come back on. Okay, thanks, Becky. Thank you.
Perfect, thank you. Okay, so we're now going to move on. So I'm going to go back to sharing the slides. And I'm now going to hand over to Gavin to go into the first section on predictive modelling.
Thanks, Becky. Morning, everyone. So just a cautionary note up front, I've had some bandwidth issues the last couple of days. So if my sound drops out, if someone can put a message in the message bar, then I'll stop talking for a minute and see if I can sort it. So we just thought it'd be useful to run through some pointers really in terms of predictive modelling and some of the work that we've been doing in the Southeast around reviewing the literature and data that might inform some of our predictive modelling and restoration and recovery plans. So sort of spelling out some of the thinking behind that. And I just wanted to say a huge thanks really to the co-author of the paper that we've produced in the Southeast, Vicky Sopp. So she's a research assistant at the University of Sussex, and actually she's put a phenomenal amount of work into this. So none of what you're about to see would be possible without the incredible amount of work that she's put in. So yeah, Becky, if we can go to the first slide, that would be super, thanks. So first off, just thinking about the kind of evidence or data that might support our predictive modelling and restoration and recovery plans, I think there's probably four really key sources. So we've got the pre-existing research, and I'll say a little bit about that. We've got emerging research, and again, I'll say a bit about that. We've got local service data, and increasingly we're getting some really useful information from that in terms of suppressed demand, increased demand, and where in the system those pinch points already are looking like they are. And I don't think we should discount local intelligence and surveillance data too, and that includes some of the really useful information that we can get from our voluntary and community sector partners. I think what's implicit within all of those as well is feedback from young people and families. And actually that could come in any of those top boxes. So that then filters down into, I think, two processes that sit alongside each other. So one is predictive modelling. And when we're talking about when we're talking about predictive modelling, we're looking at what we can anticipate rather than what we know is already coming through the door. So I think the predictive modelling of demand particularly leans more towards those top two boxes, so pre-existing research and emerging research. But we also need to be thinking about capacity too. And I think we've probably got a bit of an iterative cycle there between the predictive modelling and emerging findings, but also emerging local service data, so we can constantly be cross-checking whether our predictive modelling looks like it's being borne out in what services are seeing or not, and if not, we need to adjust that modelling. And then that predictive modelling of demand and capacity then can feed into restoration and recovery planning alongside all of that other information and data. Okay, so if we could move on to the next slide, Becky, please. Thanks. So this was just a bit of an example. So this is what NICE call hierarchies of evidence. So when they're developing NICE guidelines, this is the hierarchy that they're looking at in terms of the robustness of the evidence that they're basing their guidelines and recommendations on. So I thought it's a useful reminder, but I think that the caveat here is that a lot of the emerging evidence in relation to COVID and the impact on young people's mental health is from survey data. A lot of the emerging evidence is also from studies that have had to develop really rapidly. So I think when we're looking at emerging evidence, we probably need to be slightly less stringent in our criteria around hierarchies of evidence. And I'll unpack that a little bit over the coming slides. But I think we can probably still apply this hierarchy to some degree to the pre-existing literature that we might draw on. Okay, so next slide, please, Becky. So just going to have a few slides talking about just some pointers really on navigating and interpreting some of the research that's out there. So first point really is that although COVID's unprecedented, there is pre-existing research that we might draw on, and there are factors that's looked at that might be a best approximation of the current situation. So I've put some examples there. So there is some research on the back of prior pandemics. There's quite a substantial body of research about quarantine or social isolation and the impact that has on young people's mental health. So I do think there's stuff there that we can draw on. When we're drawing on that, though, we just need to be cautious and think a little bit about some of these points under that second bullet point. So how directly comparable the conditions were. So an example here might be that maybe studies looking at prior pandemics might be more applicable than studies that have looked at, say, a one-off terrorist incident. Are the prevalence rates similar across the study? So when they're looking at the rates of mental health difficulties, actually, are there commonalities across them? Because if there are, maybe we can be slightly more confident in what they're saying. We need to obviously think about the methodology and how mental health has been assessed or measured. Now, I'll come on to that again in the next couple of slides. We need to look obviously at the sample that they've looked at. How large was it? What was the age? What was the nationality? Was it representative in terms of the demographic features? And again, I'll come on to that again over the next couple of slides. Whether other influences on mental health were controlled for. So I think the language that's used in research is counterfactual. So where would mental health have been anyway without these events or without these factors being in play? And also whether they tracked young people over time. And that again comes in quite a lot when we're looking at some of the emerging evidence and emerging literature, is that it isn't necessarily looking at a longer term mental health impact or sustained impact. Okay, if we can go on to the next slide, please, Becky. So I've got a couple of slides now just on interpreting emerging findings, and I really do feel quite strongly about this, that this is really important, because I think there are a lot of reports being published by a whole bunch of different groups. Some are research, some are survey, and there's some really, really useful information in there. But I think there are also potentially some things that headline grabbing, that when you dig underneath, there's a little bit more subtlety to it that we just need to be thinking about. So the first point here is how representative is the sample. A lot of the studies and surveys have self-selecting samples, and they're not necessarily representative when you look at the demographics. So often more vulnerable or marginalised groups might be missing. How is mental health assessed or measured? Again, as I say, there's a lot of surveys out there, but they're not necessarily using recognised mental health tools or validated mental health tools. So we might take something different from that in terms of whether that indicates a mental health difficulty that is going to meet criteria for diagnosis or necessarily require a service. Most of them, if not all of them, lack a baseline pre-COVID measure of mental health for the young people in their sample. So that does create some limitations, because we don't know whether we're looking at changes in mental health there. This next point, I think, is becoming increasingly apparent how important this is. At what time point during the pandemic was mental health measured? And particularly for children and young people, I was thinking about this last night, there have been multiple milestones that might have had an impact on how a young person would have scored their mental health at that particular point in time. So we have things like the announcements about whether schools were opening or not and which years were going back. We've had when the exams were due to be, when leavers events were due to be. We will have the exam results over the summer. We've got the return to school in September. We've now hit the summer holidays, but most children have had a period of 3 or 4 months of not being in school anyway. Coming into the summer holidays, we've got maybe parental return to work. So it kind of feels like we are constantly working with shifting sands here, and will continue to for some time to come. So I think we do need to bear that in mind when we're looking at some of the findings. These last 2 points for me are probably I apologise, are probably slightly soapbox issues. So a lot of studies that are using mental health measures are reporting mean scores. So the mean score is the average score for the sample that they've used in their research, or for subgroups within that, say females versus males, for example. And that's fine, but they are limited. So they're limited in 2 really key ways. So one is they don't tell us the spread of scores or the range of scores. So what it's not telling us is how many young people maybe fall at the extreme of maybe the severe end of the scale with the measures they're using, which is potentially really important information for us and our services. The second limitation, really big limitation, and we're starting to see this come through in some of the reports that are being published in both adult and children and young people's mental health, is that we're starting to see some headlines in terms of changes in mental health over time, over the last month or the couple of months in lockdown. And I've seen a couple of reports from adult and child research that's saying there's been significant reductions, statistically significant reductions. And part of the issue with means is that when they're reporting change over time, that's a group average. What they're not telling you is how individuals in their research sample are faring over time. So it might be that the group average has changed or come down, but it might be that you've got a subset of that sample who really haven't improved at all, or maybe have got even worse. And so the means aren't really capturing that. And then that final bullet point also kind of follows on here. So when they're reporting statistically significant differences, actually there's two really key studies, one in adult and one in child, where we've scratched under the surface of that a little bit, and the scores have reduced, but a very small amount. And the scores are still in the same range on the measures that they're using. So there was a study that's used the Strengths and Difficulties questionnaire, and the average scores for the sample started in the a mildly above average range, and they've continued in that range, but they've just reduced enough for it to be statistically significant. So I just think we need to be really, really cautious when we're reading some of those findings about mental health changing over time. And that's not wanting to be a naysayer, because hopefully things will improve as time moves on, but we just need to be a bit cautious. Okay, Becky, if we can move on, that'd be super, thanks. However, having said everything on the previous page, studies have had to be implemented rapidly, so we need to be open that the methodology isn't as robust, and we need to not throw the baby out with the bathwater, and there is some useful information in those studies. There are, I would say, we've come across probably 4 or 5 large-scale UK studies that really do show some promise, and we're really closely monitoring those. And I'll say a bit more about that when we come on to the predictive modelling in a minute. And I think we can still interpret the emerging findings with caution. And so the approach that we took in our own paper, and I'm not saying this is the only approach to take, but this is the approach that we chose to take, is looking at where there are common themes emerging across studies, because again, we might be more confident in that if that's showing increases in specific types of mental health difficulties, or if there are recurring themes about specific groups that are more at risk, which there certainly are. And I also think that the approach we've taken is looking at whether there's common themes that overlap with pre-COVID research, because again, if we view it through the lens of those prior findings and they're showing similar things, we might be slightly more confident in some of these emerging findings. Okay, thanks, Becky. So just a few minutes on our own review, our own report on the literature and data that's emerging and pre-existing. We're hoping to have a second version of the paper maybe by the end of this week, or if not, at some point next week, ready to circulate. And there are some really key updates, and that will come out with an email just highlighting what the updates are. Our paper was intended to give pointers on the types of mental health difficulties that we might see an increase in, and on groups that we might want to be more mindful of or looking out for. What the paper wasn't intended to do was be the basis of predictive modelling. So there is a separate parallel piece of work going on that I'm going to talk about in the last couple of slides, that filters down some of the literature that we've looked at to identify the literature that's the most robust to base predictive modelling on. And the other note really with our paper is it doesn't look at interventions, but I'm aware that there's a paper that will hopefully be circulated soon that's been put together by Public Health England in the east of England that does cover some of the evidence base around interventions linked to some of the difficulties that we're all identifying might increase. So here's some of the headlines. Some of you might have read this already, so I won't spend ages on it. But prior studies of pandemics and quarantine and social isolation suggest that potentially up to about a third of young people that we experience that require mental health services, or there's some suggestion that young people are 5 times more likely to require mental health services. There are an increasing number of COVID surveys that are identifying that young people are definitely reporting that they're experiencing social isolation and loneliness. So I think we can have some confidence in those prior studies being relevant at present. When we look across prior studies of factors that might be similar to the situation we're in now, so pandemics, quarantine, disasters, bereavement, intensive care, and some of the emerging COVID-19 studies, I think in terms of the patterns, and this isn't saying this with absolute confidence, it is predictive, it is estimates, but it looks like possibly the largest increase might be in depression. And there is some evidence that that might be a longer lasting problem. There is some evidence that teenage females and young people of black or mixed ethnicity might be more at risk of depression. There is evidence of some increase in anxiety. I think most of us are anticipating that there's potentially going to be a spike on the return to school. But there's less clear evidence when we look at previous research, longitudinal research, of whether that will be a sustained issue. There's some suggestion that males might be more at risk of anxiety than females, but very tentative. There is some evidence that rates of PTSD are likely to rise. It's really hard to estimate the degree that might be, because there are multiple things that could lead to PTSD. There are bereavements, there are PTSD directly related to COVID. There might be PTSD related to interfamilial factors that have occurred during lockdown. So I think it is quite hard to estimate how much that might rise by, but I think we could reasonably anticipate that it would. Okay, Becky, if we can move on, please. Thank you. So at the moment, there aren't any current studies that are producing findings around serious mental illness in children and young people. There is a study we're aware of that is looking at psychosis, and is going to be doing some place-based research, but that's going to be much more longitudinal, so I'm not sure how soon that will be producing any findings. If you know of any studies, please do let us know, because I'm mindful that we probably haven't completely exhausted the literature base. But what we do know is that service level data is indicating that there's been significant increases in new referrals for eating disorder and really high complexity and acuity and physical risk in those referrals. And that actually in some services, those referral rates have exceeded pre-COVID levels already. Referral data on psychosis is mixed. There's some reports that it's increased a lot and other reports where it's maybe decreased a little bit, but there aren't any studies that are currently producing any evidence on that. Survey data suggesting there's an increase in behavioural difficulties, but again, there's very few studies that are using validated measures of behavioural difficulties. The theme that's coming through in that is that this is particularly true for young people with special educational needs. We know that family functioning is a key factor, and that's from pre-existing studies and emerging studies, really crucial, really critical, and I'll come on to that a bit again in a minute. There's and this probably is no surprise, but it's important to just remind ourselves of, there's compelling evidence from prior studies and from emerging studies that supportive adults serve a protective function. And when adults, and this is parents, carers, or teachers, are struggling, or where young people think that they're struggling, the young people struggle more themselves. So I think we need to bear that in mind when we're thinking about our restoration and recovery planning. Okay, if we can move on, Becky, thank you. So pre-COVID prevalence studies, so NHS Digital, the most recent prevalence study, highlights groups with high rates of mental health disorder. So these groups are children with special educational needs, children with parents with mental health problems, children living in families where family functioning is low or poor, children with general health concerns, children who identify as lesbian, gay and bisexual, and females. All of those groups we know from prior research show high rates of mental health problems, and actually there's no evidence to suggest that they're any less at risk now, and in fact there's some evidence emerging that those groups are absolutely likely to have increased in their mental health difficulties. The other thing I think to note is that there may be even more young people who fall into those groups now, so low income families would be an obvious example there, or families with lower functioning. Bereaved young people, there is some literature around bereaved young people and the types of difficulties they might be more prone to. There's some evidence that acute grief reactions can mitigate some of the risk of other mental health problems. So if we can intervene early, we might interrupt the path of that to other mental health disorders or difficulties. It's really hard to obtain accurate figures on prolonged complex grief, and they're probably likely to be underestimates, because we know that for young people who have lost loved ones or close family or friends in this time, they haven't been able to go through the same rites of passage around that we might normally be able to, or derive the same level of social support around that. There's some emerging evidence. I just saw a paper yesterday actually that's come out of Denmark, where they looked through the clinical notes of just under 5,000 young people who were open to CAMS to look at whether there were references to COVID-related additional mental health concerns for those young people. So it's very, very early evidence. It's very tentative evidence. And they found that there was about 2% of their sample had a note in their clinical notes that there was some COVID-related mental health difficulties that had emerged during this time. And when they broke that down, 35% of that was anxiety-related, 15% was OCD, and 5% was self-harm. But they note that they think that's probably quite a significant underestimate of the impact. And they also note that those difficulties were very much in line with the original difficulties that young people came in with. So if they were anxious or if they're prone to OCD, that was very much linked to them developing OCD linked to COVID. Okay, I think it's important to note as well, there's very little emerging evidence about certain groups. So children in the care system, I think that I've seen almost nothing about how they've been faring in terms of their mental health. So again, if anyone's aware of that, please do let us know. And then I'll just put a note in at the end about groups that may be particularly at risk. Becky, if we can move on, that'd be super, thanks. Right, so suggestions from our live literature and data review. And Anne a few minutes ago was talking about integration, things being integrated. I think what our review shows is that restoration and recovery plans need to be integrated across statutory and voluntary community sector. I think ideally they need children and young people's and adults' mental health and emotional wellbeing support needs to be linked or integrated. There's a lot of evidence that when the parents or carers aren't doing well, the child isn't doing well, and vice versa. So there's that bidirectional influence. So I just think we need to get in the pattern of thinking about the adults when we're seeing children, think about the children when we're seeing adults. So there's this concept of wellbeing hubs that's emerging in adult mental health, but I wonder if that's something that we could consider how we might build on that. What we're getting increasing information about is that schools are critical. That the most recent CoSpace study was talking about families seeing schools as the most trusted and the most common source of support and advice around their children's mental health difficulties. So I think it really highlights the importance of schools. And we know that schools are a real resilience factor for children. Community-based screening, I think, and again, I think the paper that hopefully is fairly imminent from Public Health England will have some pointers on community-based screening. Signposting to support and advice, supporting lower levels of difficulty within the community, perhaps, and like I said, grief is an obvious area where we might divert the path into more serious mental health difficulties if we can get in there earlier. We know that a sense of connectedness is crucial, and there might be some really practical things that can be done by schools or communities to increase that sense of connectedness for children. I saw in some of the recent DfE guidance that they were talking about supporting young people with their emotions linked to not feeling connected. But I think there's probably a step before that, which is actually, can we facilitate young people feeling more connected? And that might be, again, a real resilience factor for them. I think also with that, we need to just be cautious of not assuming that children are automatically going to feel connected when they go back to school. So there is some emerging survey evidence that some young people are worried about going back to school and what it's going to be like around friends. And obviously it isn't going to be exactly as it was before. So they might continue to experience a bit of a sense of anxiety or loneliness, even when they're back around friends. I think the last 2 points I've emphasised quite a lot already. So if we can move on, Becky, to the next slide. Super. So specialist camp, one of the things we're all thinking about is when might the surge come? I think we're sort of thinking there may well be an initial surge in September or around September time, and that's probably going to be a combination of suppressed demand. We're already starting to see referral rates sneak back up, but also maybe COVID-generated demand, and that September time may be a combination of things. We might identify young people who are really struggling to get back into school, and where their anxiety peaks when they're being faced with the triggers for their anxiety more again. But we might also see that young people who've developed mental health problems over this period of time are spotted once they're back in school and referred on. So there may well be a surge around September time. Some of the evidence suggests that difficulties may well peak in the first year, but some of the longitudinal studies that we've been looking at have extended as much as 9 to 25 years. So I think we need to be planning for sort of medium to longer term here. I'm really conscious of just not talking through each bullet point, because I think people can read them through for themselves, but I do think there's something about looking at the young people who haven't been able to engage with the remote offer, and whether they're still being seen, how we reach out to them. I think, building on the previous slides, there is something about us maybe thinking in specialist CAM services about, do we screen for bereavement? Do we ask about that? If not, should we start doing that? Should we be asking about trauma incidents as standard and trauma symptoms, and being aware of signs of heightened grief reactions? Should we routinely be screening parent mental health? One thing I just wanted to pick up on is this sort of high-low incidence difficulties. So depression and anxiety are higher incidence. Just because they're higher incidence, it doesn't mean that we've got the resource in the system to offer evidence-based effective treatments for them. So we do need to be thinking about that. But we do also need to be thinking about maybe the lower incidence difficulties, so things like eating disorders or PTSD, where actually it is going to require a very specialist intervention at times, and bolstering that in our workforce as well. There is some information coming through about services maybe struggling to discharge while working remotely, so I do think that it's worth putting some efforts into that, and how we might support families and young people, but also staff, to be confident to do that. And staff wellbeing, let's not miss out on that. Next slide, please, Becky. Right, so that's the kind of overview of where we're at with the literature and data review. What we then think about is how we can funnel that down into some predictive modelling. So lots of people have probably seen this graph. I think a lot of people are using that in their restoration and recovery planning. Becky, can we move on to the next slide, please? So some key considerations in predictive modelling. It's a best estimate, so it's inexact. We know it's inexact. We know it's imperfect. So based on that, do you model best and worst case scenarios? Do you model a midpoint, or you do all of the above? And I think that's down to services or local areas to decide. Do you model for the whole service, or do you model for specific care pathways, or do you do both? I think probably the emerging evidence would suggest that you should do both, because we know that referral rates are picking up at different paces in different parts of the system, and we know that different types of mental health difficulties may be more likely to surface at different time points. In terms of COVID suppressed demand, obviously you can use your local referral data for that, and as we already said, referral rates we know are picking up at different rates in different parts of the system. In terms of COVID generated, the predictions are likely to be a fluid process. We need to update them. We're keeping an eye on the emerging evidence, and we'll try and keep on getting that out into the system so that you can be aware of what some of the emerging evidence is showing us. And we also need to just be cross-checking that against your local data to see how accurate that is. In terms of COVID altered activity, just want to spend a few minutes on this. That needs to be factored into demand and capacity modelling. I would suggest that contacts maybe aren't the best way of doing that. So I know Hampshire Camp's going to be talking later, and I had a conversation with Leo and Mandy last week, and they're saying that their contacts have remained relatively stable over the period of COVID compared to pre-COVID. So their contact levels haven't really dropped off, but when they've looked at the duration of contacts, the duration has reduced, and the number of contacts that young people are likely to need to discharge have increased. So contacts probably is not the best measure, because they might not show much change. Probably what's going to give us more accurate information about COVID altered activity is discharge rates, the number of new treatments started, and changes in the number of sessions taken to discharge. And it's important to consider COVID altered capacity in terms of staff sickness and shielding as well when we're doing predictive modelling. Becky, if we can move on, please. Thank you. So again, I'm sure most of you would have seen this, and I won't spend ages talking it through, but this was just a visual framework for how we might start to assess COVID-generated demand. So I'll leave that there. It's in the slides, so you can have a look at that in your own time. Becky, if we can move on, thank you. Myself and Katrina Lake, who is the clinical lead for adult mental health in the cell, have been working within this informal collaborative over the last month or so to try to develop a demand forecast model for adult and children and young people's mental health. The approach we've taken, I've outlined here. I think that this would be an approach that you would use regardless of whether you're using our model or someone else's model. So the first step that we've taken is identifying key groups of people whose mental health is likely to suffer during the pandemic. And then within the spreadsheet that's been created, local CCGs or service providers would input their denominators for that group. So their local population data of the number of people that would fall in those groups. Where available, we've then looked at the most robust evidence or research to estimate what the likely increase in mental health difficulties is for that group and what those mental health difficulties are. So we're evolving this criteria for studies that we select here, and it's a much smaller list than the list that's included in the R&R paper that I mentioned a few minutes ago. I think an important thing to note here is that some at-risk groups aren't included because there just isn't the robust enough data at the moment. So it's not meaning that we don't think there'll be a need in those groups, but we just don't have enough robust data to predictive model. Then combine the information on 1 and 2 to look at the total mental health difficulties likely to increase for those groups and come up with a figure. Becky, if we can then move on to the next page, please. Thanks. So then the model provides estimates for the percentage of people with any specific difficulty that might require a service, but that can be altered by local CCGs or service providers. So it might be that you have service models where maybe mild to moderate are dealt with in a different part of the service. You might have a different remit, you might have different access targets. So that percentage can be tweaked, but it will then translate that into an estimate of the potential number of people who are going to require a service in each of those groups, so that you can then look at an overall increase in demand for the service or certain pathways within your service. And this is where it gets a bit trickier. It's trying to look at the potential overlap between groups. So for example, for children and young people, the vast majority of children and young people might have experienced social isolation in this period of time, but there'll also be a proportion that have experienced bereavement. So we need to try to account for that overlap so that we're not overestimating. So we're trying to come up with a discount factor, but again, that can be adjusted locally, and you might have local intel that helps to inform that. So then once you've done all of that, you get an output from the spreadsheet or your own modelling tools, which you can then add to the local data on suppressed demand, and that will then give you your figure on anticipated demand. The challenge then, I think, is thinking about when and where that demand might enter the system. And some of that might be based on the types of difficulties. So as I say, you might have, say, for anxiety, that voluntary and community sector see a lot of young people with anxiety, and only a certain proportion will come into you. Within the tool we've come up with, and this really isn't a sales pitch, I think whatever tools you use, they're all estimates, and as long as they follow similar principles, that's fine. Within the tool that we've used, we've tried to keep the assumptions transparent so that people can see what the formula is and what the assumptions are that are leading to the figures that you're getting. There is a plan that it's going to be a dynamic tool because the evidence is constantly evolving. And so I just wanted to finish up. We've got a few minutes, I think, just showing the spreadsheet so that you can just visually see how it looks, and then I'll finish up. Okay, so hopefully, I'm hoping everyone can see this. So if I just take rows 9, 10 and 11. So this was a factor that we felt would impact on the general population rather than necessarily a subgroup of young people. And this was around social isolation and quarantine. The studies that we're basing it on, we know, are 5 to 19-year-olds. So this has been populated. So column F has been populated by a trust who've been collaborating with us on this. So this is their local population of 5 to 19-year-olds. So they've got 176,745 5 to 19-year-olds in their local population. Column G then is the forecast increase. So we've looked at the reliable, robust enough studies into social isolation and quarantine and what they predict the increase in depression might be, or the rates of depression might be. What we've then done is taken out the baseline prevalence, so the normal prevalence rates for depression in usual times from that figure. And that then has arrived at 15.9% increase. So then we move along to column I, and what we've got there then is the forecast number of young people, the increase in young people who might be experiencing depression as a result of social isolation or quarantine for this particular CCG. Next column, so column J, this is what I was talking about in terms of the number that we're predicting might require services, so you can tweak this locally, but we've just started off with a 50% require services. So that then leads to a predicted increase in demand in services for young people experiencing depression of 14,051. So hopefully that's made sense and just gives a bit of an illustration of how the tool might work. I feel like I've spoken a lot. I'm going to stop now, and we've got a few minutes for questions, I think, before we move on to the second part of the webinar.
Thank you very much, Gavin. That was excellent and very, very helpful. So we've just got a comment from Tim.
Did you want me to talk to that?
Yeah, could you? I think that would be better. Sorry, Tim, rather than me read you.
Thanks, Gavin, for that. It's not intended to be a so what, but there's a sort of elephant in the room for us in terms of we've been doing quite a lot of work with Hampshire CAMS around some of our modelling of increases in the action that needs to be taken to help address that. One of the issues, we're not getting pushback from the CCGs, but one of the reminders that heads of finance and CCGs are sort of giving us is that that's great, but actually, we don't know what our budgets are yet for 2021 because of the controls, and we don't have control of the contracts, so we can't take some of this action locally. So I guess it was more a question for NHS England colleagues as to whether there's any sort of indication as to when some of those, if we're going to be expected in CCGs to work with providers to respond to this, when might we be in a position to actually have the control to do that?
Becky, do you want me to come in here?
Yeah.
Yeah, sorry. I wasn't sure whether Gavin was answering. He was on mute. Yes, please do, Kerry. Do come in.
Or do you want to? It's up to...
No, go on. Carry on, please.
Hi, Tim. How are you?
I'm very well, Kerry. Thank you. You?
Yeah, good. Thank you. Hi, everybody. We are understanding that the letter, Anne said very clearly earlier that the letter from Claire Murdoch is coming out very shortly. So that will... Within that letter, we're expecting to have some clarity around the issues attached to releasing the funding. What we're being told is CCGs should be aware of their funding value, and that's identified in the plan and the financial tool. So you should know the value of your money that you've got and the value that you will have for next year. And we are awaiting guidance because there's a slight issue at the moment in terms of how transformational funding that's outside of the BOP payment is being paid and the invoicing processes attached to that. So MHST, for example, is an example of how are trusts going to be invoicing CCGs in order to get their funding for the MHST work, because that's outside of the block contract. So there's two things for that. The letter should give us an indication of when that transfer of funding and payment will happen. And we are awaiting guidance from the National Finance Lead around the invoicing process. Again, all of those things we're expecting to be very imminent.
Thank you. That's really helpful. I mean, I wasn't trying to be difficult. It's just it's sort of difficult for CCGs in terms of obviously winter's coming up quite quickly. September's coming up quite quickly, and some of the things we need to do will have some mobilisation sort of run-in time too. So,
yeah,
Tim,
completely.
I wonder if there's another issue that runs in parallel to this, which is looking at existing capacity and particularly skill mix in the system. So if you've got predictive modelling that's highlighting specific types of difficulties that may be most likely to rise and the degree to which they're likely to rise, before any additional resource comes in, it's worth taking a look at the resource that you've got and whether the skill mix is equipped to deal with some of that, and if not, how you might upskill in certain areas. Yeah,
thank you for that. Yeah.
And I think some of it also comes back to the comment earlier from Anne and I about the integration of the restoration and recovery plans across the whole system. So local authority, voluntary and community sector, to see what resource and capacity you've got outside of the specialist camp services too. And I'm not saying that's the fix at all, but I think it's both and.
No, and that's absolutely spot on. I mean, I think it's also sort of currently a little unclear as to where local authority finances might sit by the end of this, and also the community and voluntary sector in terms of have been disrupted around some of their normal fundraising and normal activities too. So we're still waiting for some of the dust to settle, I think, on that front. But no, thank you for that. That's really helpful.
Thank you. Thanks,
Becky,
Tim.
it looked like we had another hand up a minute ago, but it's gone.
Yeah. No, Sarah Breton, I'm going to hand over to you.
Hi, Gavin, hello. Just wanted to say a really big thank you, actually, because that was a fantastic presentation. It really plays into the agendas that I know we've got locally. And so, I mean, the first thing would be, can we have that circulated and share that presentation? Because I think it would be really helpful. So that would be great. The second thing, I think, is that what I've taken away from this more than anything else is the importance of looking more widely just than the individual child or young person, and needing to look at the impact of families and the impact of parents' mental health and wider societal issues like connectedness and loneliness. And they feel so important. And what that is sort of telling us, I think, correct me if I'm wrong, but is that mental health services on their own can't do this. Our recovery plan has got to be about a whole system recovery plan, because it is about schools and connectedness, it's about families and resilience. And I think that's something that I haven't heard before. So unless I'm wrong, that's a really helpful message to hear. And finally, the other thing I would like to say is, I don't know about anybody else, but I hear a lot of anecdote about the impact of the pandemic on children's mental health. I've heard a lot of quite senior leaders and senior politicians more locally to us using some of the anecdote as a sort of grandstanding to say this is all a disaster, this has all got to cost vast amounts of money. I think we really need to help to manage some of that messaging, and some of the information that you're giving us here, I think locally, will be really helpful in managing some of that messaging back across the system. So yeah, wanted to say thank you. It's been really helpful.
Thanks, Sarah, and it's good to hear that one of the messages that you're taking away is around it being more than just about the individual child and about the system and the adults around them, and that connectiveness. Yeah, and I think we're going to hear some of that. The idea of restoration and recovery plans being system-wide over the next hour in some of the presentations.
Okay, thank you. Thanks, Sarah. And Kerry's put in a webinar that might be useful as well, which follows on from what you said, Sarah, about interventions for children and families. So I'm conscious of time, so I'm going to move us on into the second session, if that's okay. Thank you so much, Gavin. And I'm delighted that we're now moving in to hear from two systems who are going to share examples of their approach to recovery and restoration planning. And the first presentation is from Hampshire Child and Adolescent Mental Health Services. And we're delighted to welcome Leo Cooper, who's Head of Service for Hampshire CAMS, and Dr. Mandy Burton, who is Clinical Lead for Hampshire CAMS. And I didn't mention them at the start of the webinar, but they are very welcome, and I am going to share their presentation. So, Leo and Mandy, are you there?
Yeah, morning, Becky.
Morning. I'm just going to get your presentation. I've got it all ready.
Morning, Becky.
Morning. So I'm happy to steer the presentation if that's okay, and then just let me know when you're ready. We're ready for you now. Hopefully everyone can see.
Perfect, thank you. Next slide, please. Hopefully what we'll be able to do this morning is just hopefully identify two areas. One is around the work that we've been doing around demand and capacity, and I'll take the slides on that, and then Mandy's going to talk around our restoration plan. So in terms of the first slide, it's just a bit of context really as to the Hampshire CAMS service. So Hampshire has a population of under 18s of around 300,000. We have around 180 clinicians. We've got 7 community CAMS teams, home treatment and hospital assessment service, an eating disorder service, an early help service, including our single point of access, and now 2 MHSTs. Over the past few years, we've seen quite a significant increase in referrals, probably around 20%. And like many other CAMS services, we are struggling with our waiting time. So we've got about 1,500 young people waiting for assessment at the moment, and about 1,500 waiting for treatment. And then there's some figures down the left-hand side there. We receive about 8,500 referrals a year. I won't talk about the other figures. Next slide, please. I thought it'd be helpful just to provide a bit of context in terms of the impact that COVID has had on our service. So like many services across the country, we've seen quite a significant reduction in referrals. However, they are starting to increase again. And actually, in terms of rates of increase, our eating disorder service is seeing a faster rate of increase in referrals than any other part of our service. And over this time frame, we have been accepting a greater proportion of referrals into the service. Overall, our contacts, as Gavin was saying, has remained relatively stable since the beginning of the year. Those figures show contacts week on week. And the dips that you see there are the usual dips that we get around holiday periods. We've also seen an increase, again, like many other services, in terms of using digital and remote consultations. Again, that's week by week. So you can see that we've gone from nothing at the beginning of the year to quite a significant number week on week. What we have seen, though, is a reduction in our average contact duration time. That speaks to some of the narrative that we're receiving from the service in terms of not all young people being able to access a therapeutic intervention digitally. So some of those contacts are more keeping in contact type of contact rather than a therapeutic intervention as such. And again, we've seen a reduction in the number of young people starting treatment, and also quite a reduction in the number of young people being discharged from our service. And again, those are understandable in the context of COVID. So, you know, it's quite difficult to start a therapeutic intervention with a young person that's not known to us. And equally, it's quite difficult to discharge a young person from the service during these times, because some of the services that a young person may well access to support them following a period of treatment within our service are also finding it difficult. So that just provides a bit of context in terms of the impact that we've seen. Next slide, please. So I really posed the question, is there a perfect storm? So we've seen we're a service that already has challenges with our capacity. there are clear impacts of COVID-19, and as Gavin is saying, the research is indicating that there will be a greater number of young people needing a mental health service, and alongside that we've seen some real service impacts around fewer discharges, fewer young people starting treatment. We're also getting quite a bit of narrative from our service around increasing complexity around a number of those cases as well. And clearly, alongside the prospect of a surge in referrals, that all points to us having some challenges with our throughput at a time when we will be needing to see more young people. So I pose that as a question for the moment, and Mandy will speak around some of the restoration and recovery plans and proposals that we have thought about in terms of trying to address some of that. The right-hand slide just gives a bit of an update as to what we've been doing around our predictive modelling. So we've been using demand and capacity tools for about 4 years now, and they've been independently reviewed every so often. So we had a review in 2017 and in 2019. The latest review had an independent consultant psychiatrist come in and review the tool with us. And really the aim of that tool is to demonstrate our waiting time trajectories for both assessment and treatment based on the capacity that we have available, calculate the required clinical staff we need in order to address and reduce waiting times within the service, and provide overall assurance that the activity of the service is in line with what we would think are generally accepted assumptions, and identify challenges and solutions. So it helps us pinpoint where we've got particular pressure points within the service and have those conversations. In recent weeks, we've updated the demand and capacity model to take account of COVID-19, and so we're now able to model a few different scenarios. So, for example, an increase in referral rates, or a decrease in discharges, or increases, decreases in the acceptance rate. So, as Gavin was saying earlier, it's not all just about increases in referrals. There are other factors that are going to impact the demand for our service and the capacity that we have available to address that. Next slide, please. So this is just a slide just giving a really broad overview as to how it works. The tool itself is a simple Excel spreadsheet. There aren't any bells and whistles to it. My feeling is that the power behind the tool is the assumptions that it's using and the calculations it's using, and those being informed by clinical staff and operational managers within our service. It was developed specifically for our CAM service, and it relies on connecting to our data warehouse, which means that it unfortunately can't be used by other services outside of the trust. However, what I would say is we have learned quite a few lessons over the past 4 years in terms of using it, and a lot about the assumptions that we use to try and make the tool as sensitive as we can make it. And I'm more than happy that following this, if there's people that want to understand more about that, I'm more than happy to be contacted and share sort of like the lessons that we've learned. And as I say, I'm sure there are many ways of being able to forecast and predict demand, and we're only offering one of these as an idea. The broad principles of the model is essentially it looks at the total capacity available for the service, so makes some standard assumptions around the staff that work in their service and their capacity to deliver clinical interventions, and then it looks at the total demand for the service, and clearly where the demand outstrips the capacity that we have available, we would see increasing numbers of young people waiting. So the aim really is to try and get the capacity matching demand, or in our case, because we do have long waiting times, is to get the capacity greater than the total demand that we expect to see. So that's a broad overview as to how the model works. Next slide, please. There's just some more detail around how the calculations work. So on the one side, you've got the staffing calculation. So that's taking into account working days in the month, taking into account sickness, leave and training, the assumed number of appointments that a clinician can undertake a day, the direct versus non-direct ratios in terms of clinical time, and then clearly the number of staff that we have in the service. That's a relatively straightforward calculation. It is possible to to model on different types of scenarios. So we could model on our full working establishment, or we could take into account the vacancies that we have in the service and do models based on the actual staff working on the ground, as it were. So that's relatively straightforward. And then there's a number of assumptions and calculations that are used within the demand side of things. So it's looking, for example, around the caseload and how many clinical appointments are required to manage the existing caseload. It also looks at the non-face-to-face contact time and duration over a particular month and turn that into appointments, because that's clearly a very important factor, especially for a CAM service when a lot of the appointment time is non-direct time. It calculates the number of referrals that we are then expected to receive each month, so kind of the new demand coming into the service. And that's essentially based on what's happened over the previous 12 months plus a percentage increase, because we always see increases in our demand. And then we look at calculating the average signposting rates, so how many get signposted before an initial assessment. And then we can see how many young people will join assessment waiting lists. We assume that an appointment for an assessment is slightly longer than a standard appointment. And then following initial assessment, we then calculate how many are signposted at that stage. And then that gives you the numbers that need to be added to the treatment waiting list. And then there's some additional time added in for urgent appointments. We then look at discharges. So essentially what we do is when we, each month in the model, we look at the new demand that's coming in, and then the young people that are leaving our services. So when a young person starts treatment, we add them to the caseload for the next month, and then we take away the discharges. Once you've done all those things, you can then calculate how many appointments are required to manage the existing caseload for the service, add in the new demand and take away the discharges, and you can compare that to the total available capacity that we have for the service. And then over the model works off a 9-month time frame. Over a 9-month time frame, you're able to calculate then what happens to our waiting lists month on month, and you can see whether or not the capacity within the service is outweighed by the demand or vice versa. Next slide, please. In terms of the outputs, it provides something very similar, graphs very similar to the ones that we've got here. And essentially it's just showing our contact levels, our referral rates, our open caseloads, our discharges and our signposting figures. And what we attempted to do, which Mandy will talk about a little bit more around the restoration, is provide some understanding as to what might happen to our waiting times if we were to see a 20% increase in referrals, which some may argue is could potentially be a conservative estimate. And the last graph, the yellow line there, is what happens to the numbers of young people waiting for treatment. So over a relatively short period of time, just a 20% increase in referrals would over double our treatment waiting list. Which is essentially what it is saying. Next slide, please. So in terms of next steps, some of this has already been spoken about by Gavin, and I hope to be able to demonstrate how we're linking in the work that we're doing with the work that's happening across the different cells. So at the moment, our demand and capacity model can only forecast a flat 20% increase in referrals. What we know we need to do is take into account the suppressed demand, so we can provide a more sensitive picture as to what's happening with referrals. And then we also need to be able to incorporate into that COVID generated demand as well. So what the next step that we'll be doing is waiting for the more detailed research to come out from Gavin and his team, and applying that to our local Hampshire population. And then what we'll be able to identify is a referral rate month on month, depending on when we might see the suppressed demand and the generated demand. And it will give a more sensitive insight into what might happen with our demand and the implications on capacity within the service. And then there's the altered interventions which again, we've updated the model so that we can take into account things like a reduced discharge rate or an increased number of contacts required for a young person as a result of COVID. Next slide, please. So I'm going to hand over to Mandy now, who's going to take you through the recovery planning processes that we've been undertaking within the service. Thank you.
Thanks, Leo. So I suppose I just want to say from a clinical perspective here, the recovery and planning has really relied on real-time feedback from our staff. Right at the beginning of the pandemic, we visited all the teams, and the digital platforms enabled us to hear from a range of staff. And it's just keeping in mind that those staff have a lot of clinical expertise and have been able to let us know what's been happening with their existing caseload of children and young people, and also the level of distress for those young people that have been waiting. Alongside that, the digital platforms have enabled us to hear real-time feedback from our children and young people, as there is a survey attached, and that has been really also helpful in us thinking about the support and guidance that we offer externally, because it enables us to see, whether it's the digital platforms are meeting their needs. And there's certainly the feedback from young people that face-to-face contacts is their preference, but they've also enabled us to pinpoint which particular clinical care pathways have been delivered to a very high quality on the digital platforms too. So I just wanted to say that. And the working alliance between your operational managers and clinical leaders has been really important in pulling this paper together. So we wrote a paper in May around mental health resilience and recovery planning, and the paper covered a summary of the available evidence at the time, and it's been really helpful to have ongoing conversations with Gavin over the last few weeks about the quality of the evidence that we've been looking at. So it's a really helpful presentation, Gavin, thank you for that. And I won't go into detail about the evidence because I think you've covered a lot of that. It also gave us an overview of the impact of COVID-19 on our Hampshire CAM service currently, with the existing caseload that we have and those children and young people waiting for assessment or treatment. We also talked about scenario modelling in order to highlight the significant impact of COVID-19 on children and young people across the services. And we used the Thrive framework to think about the proposed framework for the system-wide response. We really feel it's important to mobilise into some action, and the impact on our children and young people across Hampshire in terms of predicted mental health difficulties in the future, it really is crucial regarding how we work across the universal services. And we felt an obligation to put that paper out to support the thinking around a trauma-informed approach. But we do also need to think about, what in addition we can offer to our usual service, and we've got some ideas that I'll talk through in a moment. So there is some anxiety about how we, the additional investment that may be needed over a 2-year period to really ensure that mental health difficulties do not increase in the population of children, young people in our area, and that really involves us working with parents, carers, teachers and universal services generally to ensure we have those wellbeing clinics and recovery workshops in place in the school environment. So if we go to the next slide, please. So what do we expect to see? Again, I won't talk a lot about this because I think Gavin has highlighted, potential predictions in terms of increase in depression and anxiety, and females, children and young people, and children and young people who are from vulnerable groups. But in the paper, we talked about initially expecting there to be an increase in crisis presentations, and I think we're seeing in our eye-to-eye service that they are now up to the previous levels. What we're hearing from our staff and seeing in practice is that the complexity of the presentations has increased, the length of time in terms of crisis presentations has increased. Certainly in our EDT team, our eating disorders team, there's been more referrals of young people where we've had to admit straight to tier 4 and an increase in RFID referrals. We've also been hearing feedback from our learning disability looked after children's team and youth offending team that it really depends again on the system around the youngsters as to the impact on them in real time. So I think we do need to think about that in relation to the impact, over the next 2 years for some of those young people who are more socially isolated or might not have the the attachment relationships of parents of carers or the wider universal services in place to support them in terms of recovery. So in the medium term, we are expecting the impact to potentially go on for 24 months, but I think Gavin also talked to that in terms of the research evidence behind that. Again, I think if I was talking clinically on the ground, we do feel that once the pandemic comes to a true end, and it hasn't yet because there's still changes every week, both centrally and locally in the areas in relation to schools and what children and young people are hearing centrally, that we feel that there will be the aftermath effect of the pandemic once things return to normal. So in terms of the impact on children and young people who have existing mental health difficulties and neurodevelopmental difficulties and those from more vulnerable groups, we do feel that there maybe need to be longer term input. Leo's talked to the fact that we aren't discharging as many young people, so I will speak at the end of this presentation about some of the thinking around moving towards more face-to-face interventions over the next few months for those children and young people where the interventions digitally aren't having the impact that they need in order to support children and young people to recover. So if you go on to the next slide, please. So we've used the Thrive model to really think about and influence the network in terms of what health can offer, and this really is to support young people thrive. So the universal services obviously would be offering the support to children and young people for 96% of the children and young people. I agree that we do need to think about skilling up the universal workforce specifically around the impact of COVID. But really we need to be thinking about the significant adults around children and young people being able to use a trauma-informed approach. We felt that the information coming out for the Centre of Mental Health really did help us in thinking about that in terms of what we talk to our staff and wider universal services about every contact with the child or young person is an opportunity for support and healing, making sense of the psychological safety that's being questioned for many of our young people, and to provide some support around their emotional well-being. So we feel it's the ongoing conversations, the conversations that are happening in the home environment and in the classroom environment, but we do also feel a responsibility to skill up that universal workforce to be able to support children and young people with that trauma-informed approach. So we're not saying that all children and young people will be traumatised, but we feel the model around a trauma-informed approach in terms of stabilisation will really help in the next 12 to 18 months. So if you go on to
5 minutes, sorry.
Thank you.
5 minute warning.
If you go on to the next slide, Becky. Can we go on to the next slide? Thank you.
And the next one?
Yeah, that's one. That's fine. So the proposed approach to a system-wide framework, really the paper that we've written has really spelt out what we're currently delivering and what we could deliver. And this is where we feel it's really important now for us as an area to mobilise into some action. And we're happy to circulate that paper, which gives more detail. So we've given a lot of advice and information over our website, and we are directing a lot of children and young people in our existing caseload and those young people being referred into our service to that advice and information, with some webinars to support families. We've released a lot of information through the social media outlets and mental health forums for schools, but we would like to offer wellbeing clinics for children and young people and some recovery workshops in the school environment too. Alongside extending our mental health ambassador scheme, which has been piloted in one area and was really helpful in terms of skilling up children and young people to have those conversations as peers with each other, and that's been really successful. And the care programme and training for professionals we think is really important. We also pull apart what getting help may look like from our service and what we'd be expecting from other services. So we talk about the Discovery College. We're in the process of pulling together our blended model through the Mind District, which will target early intervention and prevention. And obviously the examples that we have from our mental health support teams in terms of being able to provide low intensity CBT interventions within a wider range of schools, we also feel would help over the next year to 2 years. So it's really about resilience planning for existing services and being coordinated in the way in which we offer from health what we can offer, but also then bring in the universal services to provide what they can. And if we can go to this final slide, please. Okay, so the other aspect that really needed our thinking from as a clinical leader was how do we support our staff to make the clinical judgments and decision making around moving from only seeing those young people in crisis to really thinking about the interventions, the therapeutic interventions from face-to-face to digital. So our clinical leaders pulled together a decision-making tool. Now this is a tool that really guides our staff to think about how they formulate the decision as to whether they continue digitally or need to move towards more face-to-face interventions. So on the left-hand side there, you've got the aspects that we felt was really important for staff to consider around safety, around the complexity of clinical need, around the particular assessment or intervention that they're going to offer, and then individual factors. And we've considered there both staff factors and how our children and young people feel about digital interventions or face-to-face, and then around the environment as well. And obviously all services are doing those risk assessments. So this tool really is for staff to have a look at and then think about the particular young person on their caseload and take this tool to supervision, recording notes, how they're making those formulations around how to provide the interventions moving forward, so that children and young people can be discharged out of the service in a timely way, and that it's not holding back and entrenching mental health difficulties in the longer term. So we just wanted to share that with the network, and we're happy for other people to look at that. And this has informed some of our ways of thinking in terms of moving towards face-to-face interventions, obviously alongside the minimum clinical standards. And it doesn't replace clinical judgment, it informs and supports clinical judgment. Okay. I hope that was helpful. Thank you, Becky.
That was so helpful. Thank you, Mandy. There are some comments in the box, but for time, I think what I'm going to do is hand over to Oxford and then pick up those comments in the box, if that's okay. And then maybe we can pick up some of those there. But thank you so much, Mandy and Leo. That was incredibly helpful. And I think you'll see that reflected in their comments, and if you're happy to share anything. So I'm going to hand over. So we're delighted I'm just going to stop sharing what I have. I'm delighted to welcome Andrea Shand, who's Head of Service for CAMS and Eating Disorders across Oxford Health, and Lila Johansson, who's Senior Commissioning Manager for Oxfordshire CCG. So I'm just going to get your slides ready to share. So give me 2 minutes.
Thanks, Becky. It's just to say also we have Dr. Vicky Lackenham joining us. Vicky is our Deputy Medical Director and Consultant Psychiatrist, and we also, I saw Paul had been able to join, so Professor Paul Stallard, who is Head of Psychological Therapies for our BSW CAMS, is able to join as well. Okay,
I won't be long. I will give you a 5-minute warning if that's okay, just to the end, but
I mean, I can start talking whilst you get it up, if that helps. Yeah. So we are presenting today on behalf of all of our CAMS provision in Oxford Health. So Buckinghamshire, Oxfordshire, Bath and North East Somerset, Swindon and Wiltshire. So we cover the 5 areas, and we have our recovery planning approach. So there are some localised approaches, but the significant part is covering all of our CAMS. If we go to the next slide, please, Becky. Thank you. This is just some wording and kind of about our aim and our approach that we've applied. It's the same kind of picture really as other areas. So we saw a quite significant decrease in referrals, over 50%, really kind of from the end of March. We are seeing an increase now. Our referrals did decrease, but actually our COVID response moving to digital has significantly increased our contacts. So our digital consultations, we did some, but not many, and we've actually seen a 90% increase in our use of digital consultation, comparing kind of June to January of this year. And we've seen a 20% increase through the COVID period in our follow-ups. So we're kind of doing various things to track. There's lots of things we have been doing. We're going to focus kind of on some key areas today, and one of them is kind of our approach to surge planning, demand and capacity, and then our CAMS forward planning group, which will be kind of a big part of our presentation, staff wellbeing, and then our system-wide approach, which Lila will talk about. So we have developed an in-house surge tool through COVID, which looks at kind of pre-COVID activity during COVID, and then adding some formulation in with regards to kind of surge planning. So it covers referrals, number of assessments, backlog growth, follow-ups, DNA. It has in whether we would see a 10, 20 or 30, whichever % increase in referrals and what that would look like, but then also how that would grow our backlog. We have developed that. We initially worked with our P&I team to develop that for CAMS, and since then it's kind of gone on and it's available trust-wide, so not just mental health, but also for our community services and our specialist services like dentistry and forensics, etc. We then have linked into the CREST tool that has been made available nationally. So we've designed our surge planning tool that's available on our, we have a data warehouse kind of Toby system, which is accessible to staff. And so the surge tool is, we've linked it to the CREST tool. We've managed to put the link to the CREST tool into our surge planning tool. So the surge tool will give the outputs that you then need to input into CREST, which means we can then kind of start to model what capacity we would need on our predicted demand. Now, the bit that we haven't, our next step to that, which hopefully the kind of the second release of the paper that Gavin mentioned will help us, is where we'll kind of then apply more formulations from the research about kind of, well, we could predict to see a 10% increase in anxiety, or within this pathway, kind of our getting help pathway, for example, so we can really drill it down into much more detail. Could we go to the next slide, please, Becky? So through kind of our COVID response, our lead clinicians formed a CAMS forward planning group, which is a clinically led group that also has operational leads involved, and myself as head of transformation. And the purpose of the group is to ensure across all of our 5 areas that we're working proactively and kind of strategically together, and in a timely way in our response to the immediate COVID response, our surge response, and kind of really planning for the future that kind of Hampshire and Gavin have also mentioned. We also have linked all of our surge planning into our local transformation programs within the organisation, and they very much will form part of the kind of LTP refreshes that were mentioned earlier. So I'm going to hand over to Vicky now, who will kind of talk about the work within the CAMS forward planning group. And I'm really pleased that it really aligns with kind of Gavin's presentation and also Hampshire's. So Vicky, are you okay if I hand over to you?
Yeah, that's great, thank you. Could we have the next slide? Thanks. Similarly to Hampshire, we've worked on a Thrive model. So we've thought about a sort of multi-tiered approach to need. And we've tried to think about what our response would be as part of that sort of system-wide response that we've been talking about earlier. So we're thinking about how can we support young people who can manage their self-care, those who need to be best supported by others, those who need a specialist CAMHS intervention, and then crisis planning. And so some of the enablers that we're sort of working through with that is a lot of digital working, obviously in terms of actually working individually with patients and families, but also thinking about our sort of technological and digital offers underlying that. So we've been running some of our groups, for example, our DBT group and our RODBT group, we've been running them online. It's been challenging, but we've managed that. We've also done our multifamily groups for anorexia online as well, and we're sort of in the process of writing the paper on that. So that's, and along with our website, which we're upgrading as part of this response as well. And I'll talk a little bit about some of those things a little bit later. And the other thing that we've been really focusing on, which I think Gavin mentioned, is about staff wellbeing. And one of the advantages, I guess, for us as a large trust is that we get sort of feedback and input not only from national and sort of but also the regional meetings as well. So actually we can hear about best practice in lots of places, which is really helpful. And actually COVID has been quite helpful in as much as it's brought us all together, because we are a big trust and it's very difficult to geographically to all meet up, but we can do that much more easily on Teams. And so that's been a really positive response. So the next slide, please. So looking at all the sort of information that had come out, including actually Gavin's paper as well, we sort of looked at some areas that really we thought we needed to develop a strategic approach for. So this is sort of the principal areas that we've been looking at. Some of those, obviously, it's a CAMHS-led response or partly our MHST-led response. And some of it is actually feeding into a sort of system-wide response and thinking about our liaison with schools, social care and primary care. So we've been doing that as well. Next slide, please. So we've sort of split up into groups. So as Andrea said, we've had sort of clinically led group, a clinically led group, but we've also had operational managers there as well. And we've divided off and each taken various topics to kind of go away and get other clinicians across the trust involved in, and those that work's then fed into our local clinical reference groups, because obviously having 3 different CCGs commissioning us, we need to think about our local offers depending on local commissioning. So I just thought we'd just highlight a couple of those activities that we've been doing. So one is really about sleep and our digital offer around sleep. So we've been upgrading the information that's provided on our website, and we're collaborating with Oxford University Hospital on a video around sleep, thinking about information, problems, ideas for people to manage their own sleep difficulties. And then we've also got Sleepio, which is an NHSX funded project, which is being evaluated by the University of Bath, and Paul Stallard, who's on the call, has been instrumental in leading. And this is now available as a first line intervention for those with mild and moderate anxiety problems, which then have sleep as an issue. And the programme is online, and people will be offered then to have facilitation by a psychology assistant. So we're hoping that once we've had that evaluated, that may be something that can go forward. We've also been able to roll that out for staff as part of the wellbeing of staff across the whole trust. So that's been really helpful. The other thing we've done digitally is thinking about video resources. So obviously our sleep resource will come into that, but we've also been developing some resources for anxiety and low mood and depression. So these have been co-designed and co-developed by our participation group. And they're really thinking about self-help information but we're also recognising that obviously if there is an increase in demand, which we may not be able to manage immediately, so we may assess people but not be able to give them as much therapy as quickly as we'd like, that actually we could use these self-help tools as is a sort of facilitated way to actually help people to manage their mood or anxiety before they get therapy. The young people have also been preparing videos on how to get ready for your digital consultation, and also because we have had a number of young people who have been quite resistant to the idea of digital consultations. Some of our young people have also produced a video encouraging people to take them up, so that we've got the option of face-to-face or digital. The other area that is something that's become more apparent, I guess, for us locally is the number of young people with ASD and LD who've been presenting in crisis. And so we've done some work again on our website, thinking about supporting digital detox for them, thinking about using PBS and getting staff trained in PBS, and using that as to support difficult behaviours. And we've also been working on an online assessment for ASD. Obviously, we can do sort of developmental assessments digitally, but it's much more difficult to do the individual assessment. So our NDC team have developed the OVAT, which is the Observational Autism Assessment Tool. We know that some people that won't be adequate and they'll need a face-to-face ADOS, but for others this may be enough, because it offers sort of similar assessment to ADOS in as much as it gives the social presses that allow people to observe the signs and symptoms, and hopefully that will be enough for some of our young people. And so that's being rolled out across the trust. So we've got the Oxford NDC and Bucks NDC teams doing that, and then it's also moving into BSW as well. Can I have the next slide, please? Andrew's already spoken about our surge planning. The other things we wanted to kind of highlight from this section is really thinking about staff wellbeing. And we've done several surveys, some local, some across the trust, just to see about people's reaction to working digitally, their well-being and how they're managing that. We've been producing newsletters for staff and encouraging them to write in with information. We've been asking them to nominate their COVID Heroes of the Week. We've also been offering online coping support groups, just to replace some of those kitchen and corridor conversations that you can't have in a formal team meeting. And we've been really trying to support staff with normalising how difficult things are. Some people have embraced digital working and find it fits in with their work-life balance very well, but other people find it very difficult. So we've been supporting people through that. And the other sort of area, just a little bit to add to the forward planning group. As I said, really, it's been very helpful to be able to meet as a whole trust to be able to plan. And we then feed into local clinical reference groups, and then that feedback goes back via the sort of management meetings to team managers, who can then highlight things to staff, as well as through our weekly newsletter. So it means that we can keep everybody up to date with what's going on, and hopefully support them as things change over the next few months. Thank you. I'll hand back to Andrea.
Thanks, Vicky. Thank you. So there's lots, that was kind of a very quick whistle-stop tour of our highlights. There's lots more detail under each of those sections. Could we go to the next slide, please? Thank you, Becky. So we kind of just looked at opportunities and risks. So, you know, we, through our staff feedback and kind of regular check-ins, the kind of leadership and staff and the kind of autonomy that COVID has actually brought has been really well received. Huge focus on staff wellbeing, the digital consultations, and further kind of we have a really good partnership in kind of all of our areas, but actually it's kind of bringing more opportunities for further integration across the system. The risks, as we kind of all spoke about, are kind of surge, the school return, backlog growth, fatigue of staff, the actual staff that have been shielding and then are returning, COVID safe estates. We now also need to consider kind of the winter pressures and COVID wave 2. Our current focus kind of in this kind of 2-week period is around the COVID, what we're calling kind of COVID safe estates. I mean, we're never going to be fully COVID safe, but what we're looking at is reopen. We haven't shut our doors, but actually to increase our red and amber cases coming back face to face, and those where kind of digital solutions have not worked or been appropriate. So that's our main focus at the moment. If we go to the next slide, so Lila can kind of talk about our system approach.
Right, I'll just unmute myself. So, we're in Oxfordshire, this is specific to Oxfordshire, we're really quite keen that the CAMS COVID plan didn't sit in isolation, that we took a systems approach to it. So we have a children's trust in Oxfordshire, and we have a plan that's a plan for the system, all partners in the system, and I'm not going to go through all these priorities, but what we've agreed is that for 2021 is that we will do joint recovery planning at a strategic level, and priority 4, if you put up the next slide, Becky, relates directly to sort of mental health services. One of the things we want to do is really realise the ambition and future in mind around how good mental health is everybody's business. And so there's really good sign up at a strategic level that's starting to filter down, as Andrew was indicating, to operational teams, both across social care, education and CAMS services and other children's health services. So one of the practical things that we've put in place is the multi-agency network meetings, weekly meetings that happened in the north and the central and south of Oxfordshire, and they have education, they have social care, they have the mental health support teams, CAMS, third sector involved, police, and the feedback so far of the meetings has been very, very positive, and these meetings will be formally evaluated to see how we take them forward. And basically it's a place where schools can book in time for consultations about children where they have concerns about, who more a sort of preventative way, instead of going down the more formal route of saying we want to refer these children, but it's a place where we can have multi-agency discussions and thinking about who's best able to support the children. And actually I think we all realise that we need to be pooling our resources, and families who need extra support, or children who need extra support, don't neatly fit into one service or one category. So there's some really quite exciting opportunities that we're hoping to take further. And also for us specifically in the NHS, it is about continuing to work in partnership to deliver the long-term plan ambitions and to increase the mental health support access rate and deliver the mental health support teams. And they're very much in the mix within these multi-agency network meetings. And I think, you know, really like Hampshire said, it's critical that we have an integrated approach to surge planning for children, to think about, you know, there is no wrong door, and how do we do joint thinking around actually preventing and stopping children from needing more specialist CAMS services.
Thank you very much. That's incredibly helpful. Thank you. And I just want to take the opportunity to thank all the speakers, but I think it's been excellent, and particularly Oxford and Hampshire, because I know our time's been quite restricted. So before I hand over to Gavin to conclude, I think because of time, we're not going to be able to answer questions, but we will take the chat and maybe if we then go to the relevant areas and then see what each area is happy to share. I know that they'd be happy to share their slides, but then take forward the key comments and questions, if that's okay, and maybe have some virtual updates. So can I hand over to Gavin to just conclude this webinar, if that's okay? Thank you.
Super, yeah, thanks, Becky. So before I try and sum up, again, just wanted to reiterate what Becky said and thank Becky as well, actually, for pulling it all together. But thank you to Anne. A huge thanks to Layla and Andrea and Vicky and Leo and Mandy. Leo's coming on his annual leave to present. Hopefully it's been a really useful couple of hours. I think it's been helpful to hopefully give some pointers around considerations in predictive modelling and restoration and recovery plans. We've heard about some really great tools for various elements of that hopefully people might be able to access if they would be useful. I think we've heard about some of the evidence. I think it's been really helpful to hear about some of the local intel and data, especially around activity, and perhaps for services to hear from each other around what they're finding around their activity levels and what those activity levels entail, and hearing about some of the work streams and activities and innovation in restoration and recovery planning. I think there were just four really key headlines for me. These aren't exhaustive. I'm sure there are other points people have taken. I think one thing that kind of struck me from what everyone was saying is that is that restoration and recovery planning, I think, is probably a both and approach. So both system-wide and looking within CAMS. I don't think that we can just focus on one of those areas. I think there's really strong messages coming through about the need to work with adults and in terms of families, parents, carers, also sort of teachers. There was something for me about that maybe we didn't go into masses of depth about how you manage surge in one area of your service without deprioritising others. It was really useful to hear from both Hampshire and Oxford about risk. And thinking about skills to actually intervene with young people who are showing some behaviours that might put them at risk, rather than just risk management. So that was really great. I guess the other plea would be not overlooking specific mental health difficulties, and I know that's looking at a real micro level, but there are pointers from the emerging evidence about specific types of mental health difficulties that we might see in higher frequency, and really making sure that you've got the evidence-based skill sets to work with those within either your services or the wider system offer. And the last point for me really is, and this really followed from Oxford's presentation, but also to a degree from Hampshire's, is how do we communicate to families and young people the self-help tools or advice that is available. And it kind of feels like it's quite overwhelming at the moment. There's a ton of stuff out there, but one of the recurring themes in several of the surveys that we've looked at is families and young people saying that they're not quite sure where to look. And I'm not sure whether that is just they're not sure where to look, but whether that is also around they're just overwhelmed and they don't know what's a decent quality bit of support and advice or not. So I think there is something about how we communicate that effectively. And the Coast-based study was quite interesting in that schools were highlighted as the main source of support and advice and the most trusted source of support and advice, and CAMS didn't feature on the list. And I don't know whether that's because it wasn't an option for families to tick in their survey, or whether just that isn't where families think to go to for support and advice. So just kind of wanted to end on that really, in terms of thinking about how we get that communication out there. I'm conscious, it looks like Layla's got her hand up. So Layla, did you have something that you just wanted to add on that before we finish up?
I just wanted to respond to that. I think the way we think about it in Oxfordshire is the schools are increasingly becoming communities around families, and we very much see the schools as a key partner to pass on that information around self-help tools and how we can support them early on. And I think it probably is right that families aren't thinking CAMS as a first off place to go. And so we have a portal that Education has put together where we post all the support tools and all the stuff that's coming through the Department of Education that school can access, and then they send that out in communication to families. And we've had quite good feedback through a mental health support team so far around that working reasonably well. Obviously still more work to do.
Thanks, Layla, and again just illustrates that need for it to be system wide and that engagement with other partners. Yeah. So if I do you want to draw us to a close, Becky? I'll turn on mute, and you want me to? Okay. So look, thank you everyone for joining. We know that time's very tight at the moment. We hope it's been helpful. I think you'll get a notification when the recording is uploaded and live, and we'll circulate the slides. And also, if any of the presenters are happy to share tools, then we'll obviously keep you posted and updated on those and the update to the paper. So thanks for joining us.